this excellent academic fiesta in the form of webinar by the Docplexus. I am Dr. Tejas Patel, interventional cardiologist at CIMS Hospital in Ahmedabad. And today with me, Dr. Kevu Parikh will be on chair as a panelist. Today there will be two excellent sessions by Dr. Ralph Brindis. Actually, he is the professor of medicine in University of California, San Francisco in US. And he has been awarded many prestigious awards, as well as he has more than 400 published manuscripts in various journals. So today is going to talk about the future of the medicine and future fate of our fate of medicine or a medical person, and dual antiplatelet therapy, which is really very interesting in the current scenario. So let's go for the first lecture, and then we'll go subsequently second lecture, and then there will be the question answer session at the end of the second lecture. You can put your questions on the chat box. Meanwhile, the presentation is going on.
So I'm going to give you a cardiovascular perspective of how clinicians can prepare for their future. But in the interest of our audience response system, I came from Bhutan right before coming here. And so I'm going to ask a question of the audience. Which of the following is not one of the 9 determinants of Bhutan's gross national happiness? So maybe we start with timer. Is that how that works? Go right ahead. Is it psychological well-being, health, education, living standards, wealth, or time use? It turns out that it is wealth is not a determinant of happiness, interestingly. And they actually have a big initiative in evaluating what the non-determinants of happiness in Bhutan. I was trying to learn something from them. Maybe I could become more happy. But you can see how it's related to living standards, well-being, health, time use, education, good governance, cultural diversity, and ecological diversity, and living standards is their gross national happiness. So what is the issue in 2020? Whether you're a cardiovascular specialist or an internal medicine specialist, think about 100 years ago. We didn't have antibiotics. We didn't have iPhones. We didn't have TAVR. We didn't have clinical practice guidelines. We were sitting at the bedside, holding our chin, wondering, how are we going to make this patient better? Turn forward to 2020. We now have to think about quality, accountability, transparency, and cost. Those are the things that people are asking us at a governmental level, at a hospital level, in the C-suite in terms of how we deliver care. In the United States, we have learned that unintended variation is stealing healthcare blind. Literally, 1/3 of all dollars spent in healthcare in the United States is total waste. Waste. And a lot of that waste has to do with unnecessary services. When we think about the cycle of clinical therapeutic effectiveness, we think of a concept of an idea, whether it be a new drug or device. We then go forward with clinical trials. If the clinical trials show efficacy, they get incorporated in our clinical practice guidelines. If they're really important, the things we must do, beta blockers, statins or whatever, they actually be incorporated in performance measures. We then go out and do the work. But to be able to be successful, we have to measure what we do, particularly in registries or outcome reports. And that actually determines our outcomes and how we can become more appropriate and more efficient in the demonstration of quality. Interestingly, in this cycle, a lot of these things that we have measured can actually lead to new concepts, new ideas, new clinical trials. So that's the cycle of effectiveness. In terms of high-quality cardiovascular disease procedures, is choosing the right patient for the right decision in the patient preferences, understanding in the context of clinical practice guidelines or appropriate use criteria, Then going ahead and doing the procedure correctly, the PCI, looking for the right outcomes, measuring what we're doing, quality metrics, benchmarking, public reporting, incorporating it, for example, in the ACC's National Cardiovascular Data Registry, PCI. And this is really the value equation for cardiovascular disease or procedures. Are we doing the right procedure in the right way with the right outcome in a timely fashion, looking at appropriateness, processes, and outcomes of care? Another way of looking at it in terms of the real value equation is we want a clinically defined outcome, a patient-defined outcome, such as a patient-reported metric related to relief of angina, for example, divided by the cost, and then multiplied by how often we're doing this in the right patient or appropriateness. That probably is the real value equation in the delivery of cardiovascular disease. We have a problem in the United States. I don't know if you have a problem in India, but I guess it's similar. This is a map of California, where I'm from. And this is a variation related to angioplasty for patients for non-acute PCI. Why should one area of the country, of the state, have 5 times the rate of angioplasty than the mean? Are those patients different? Is there variation of care that is unacceptable? In my strong opinion, is that this marked variation shows opportunities for improvement. Now, in the United States, I don't know if this is happening here in India, despite all the advances of interventional care, we're being attacked by the payers and the government related to what we do. We actually have an image problem in the United States related to interventional cardiology and doing inappropriate procedures. You may have all heard of Dr. Oz, the TV personality, a cardiovascular surgeon from Columbia. He, on his TV show, said 50% of all angioplasty is inappropriate. 50%, that's what he's telling the population. Did he get it right? No. We know this because we're actually measuring what we're doing related to appropriateness in our National Cardiovascular Data Registry, and it's much lower. It's more like 4 or 5%. So the ACC actually came up with a document looking at appropriate use criteria to help guide clinicians and also inform payers and purchasers and patients about what we're doing. And the question that I was asked by my interventional colleague, you're shooting us in the foot. Why are you creating such a document? And the answer is, there's a continuing and reasonable question about what we do. And if we don't create documents like this, someone else is going to do it for us or to us. And clearly, the cardiovascular profession and the medical profession can create such documents better than anyone else. So what are we talking about when we talk about appropriate use criteria? We take the evidence from our randomized clinical trials and registries, expert consensus, we create our clinical practice guidelines. And as I mentioned in that slide of the cycle of clinical therapeutic effectiveness, that determines what performance measures and appropriate use criteria. And the goal here is to increase the use of effective therapies, decrease the use of inappropriate, unnecessary, and harmful therapies to improve patient outcomes and reduce costs in our healthcare delivery system. So what about this appropriate use criteria document? What does it do? So it actually takes, in this case, stable ischemic heart disease. It looks at different indications for the use of patients with potential use of angioplasty. It looks at whether they're asymptomatic or symptomatic. It looks at the amount of anti-anginal therapy that they're on, and then determines whether it's appropriate, undetermined, or rarely appropriate or not appropriate to perform PCI in that given population. And we've actually come up with appropriate use criteria tables related to this. In a simplistic fashion, green, go light, you can do it, it's appropriate. Yellow, indeterminate, may be appropriate. And R, red light, don't do it, it's rarely appropriate. Again, appreciating individual patient variation can overcome any of these things. So this table happens to look at two-vessel disease, whether they're on or not on anginal therapy, whether they're asymptomatic or not, and this is to help guide clinicians in their work. But the bottom line, though, is we only can manage what we measure. And how do we actually know if it's appropriate or not unless we're actually measuring what we're doing, benchmarking it, and so forth? So a paper that I was involved in, published in JAMA about 8 years ago, looked at the hospital variation in non-acute PCI inappropriateness. So to put it in perspective, if you have an acute coronary syndrome, 98% of the time that's an appropriate thing to take the patient to the cath lab and perform PCI when appropriate. But in not graph, it shows that in the United States at that time, 12% of PCI for non-acute reasons was inappropriate or rarely appropriate. But maybe even more importantly related to this slide is the marked variation between different hospitals on how well they did in terms of their appropriateness. Some hospitals quite good, but some hospitals doing PCI in patients, half the time that was hardly justifiable. So the next question is, are we professional stewards of care? Do we care about what we're doing now that we have these documents, now that we can measure what we're doing? So this paper, about a couple years later in 2015, published in JAMA, presented at the AHA, looked at temporal trends related to appropriateness. Now that we have these documents, AUC documents, now that we're measuring appropriateness within the NCDR. And sure enough, in that 5-year period, we had a marked improvement with decrease of inappropriateness by greater than 50%, and appropriate PCI increased dramatically. So we are good stewards in general of our healthcare dollars if we have the ability and tools to measure what we're doing and have an understanding of the infrastructure, what's appropriate. Nevertheless, despite that temporal improvement, you can see that even in 2014, and that's still true in 2019 and 2020, there's variation among the hospitals in how well they are and what they can do in terms of appropriateness. Or as I say in administration speak, an opportunity for improvement. So how about stress PCI? I don't know if what the standard of care here is in India, but this is a paper from Dr. Parikh and my friend Pam Douglas. And what she did is she looked at the utilization of stress imaging after PCI from the Medicare database. And what you notice is these are 4 quartiles of high use to lowest use of stress PCI after a PCI. And what you notice in that red graph with the highest utilizers of stress PCI is 2 humps at 6 months or 12 months. This is what we call, I don't know if we do this here, the anniversary stress test. In other words, patient's feeling fine, but you go ahead and, well, it's been 6 months or a year, let's go check things out, do a stress test. Is that clinically indicated? Is there any value related to that? If you look at our clinical practice guidelines, the answer is no. And sure enough, she actually looked at the all-cause mortality, readmission of AMI, repeat revascularization related to these 4 quartiles, our utilization of stress testing. It did not change the mortality if you did it more often. It did not change the readmission of AMI, but it certainly increased the issue of repeat revascularization. Probably no surprise if you look, you do something. We can all improve. We need to take physicians who their efficiency and quality is in this low quartile and look at what exemplary clinicians are doing and try to move people up into that quartile. It's our professional responsibility. It's the privilege of self-regulation. Although it's onerous, we can do it better rather than have it imposed on us by payers. We have projects within the United States looking at such. One is called Smart Care, to improve outcomes, to improve the bedside application of science, to reduce unnecessary variation. We look at through a number of the ACC tools to see if a stress test is appropriate, whether they need a cath, what we should do at the time of the cath, is stenting appropriate, that we look at the quality of the stent, we make sure afterwards they have appropriate cardiovascular risk reduction, and overall quality assessment for patient-reported outcomes such as the Seattle Angina Questionnaire. And this continuous feedback and quality reports is a way of ensuring high-quality care. Smart care decreased imaging that was not appropriate. It decreased PCI that didn't meet a criteria. It improved patient quality of life, decreased costs, clearly an appropriate goal. So our take-home message here is unnecessary tests and procedures contribute substantially to the high cost of healthcare. Value of healthcare is really a value, quality, cost, appropriateness formula. Appropriate use criteria by the ACC have been very effective in minimizing inappropriate tests. It's our responsibility and privilege of self-regulation to be better stewards of our healthcare expenses. And maybe we can, as clinicians, choose wisely in a similar way, or maybe in a portion of similar way, of some of the great teachings of Gandhi in terms of his whole wheel of life. Thank you very much. Thanks everyone for staying around. I'm going to talk about a case-based update on the treatment and duration of dual antiplatelet therapy and therapy with patients with coronary artery disease. My disclosures, I was involved in a couple of the writing groups in terms of the guidelines for ACS and also for the dual antiplatelet therapy update in 2016. So we were asked to do case studies. So here's your case study. A 53-year-old Indian male bricklayer, no prior history of coronary artery disease, has 3 months of exertional chest pain compatible with angina. He underwent a nuclear stress test that showed a decent ventricular function, but moderately severe ischemia infralaterally. He's placed on aspirin, metoprolol, and a statin, and his exertional chest pain is substantially decreased, but still present on very marked exertion. So the question for the group is, well, would you do an invasive approach and take him to the cath lab, or would you do a conservative approach? So just out of interest, how many would take this bricklayer who's doing better but still with chest pain on marked exertion, take him to the cath lab? Raise your hand. Or increase your metoprolol? Raise your hand. All right, most of you would do nothing, evidently. So in this case, his cardiologist decided to take him to the cath lab, and the cath at that time showed severe proximal two-vessel disease in the RCA and the obtuse marginal branch of the circumflex. If we actually looked at the appropriate use criteria for stable ischemic heart disease, where green is it's okay to do, and yellow it's indeterminate, and red, hell no, don't do that. This patient fits with this two-vessel disease on beta blockers that it would be appropriate to do PCI, as you would see here. Now, the question now is, what do we really do with these patients? If you looked at a very important study that just came out at the AHA in November, with the ischemia trial, it actually looked at patients like this who had stable ischemic heart disease with moderately severe ischemia, who by CT we've ruled out left main stenosis, but also diagnosed coronary artery disease. And that showed after a 4 to 5 year follow-up that there was no difference as to whether we treated him invasively or non-invasively related to these key outcomes. An interesting concept, because I would think a lot of our interventional cardiologists haven't reached this equipoise yet, but it is tantalizing to see how this will change therapy. The conclusion of ischemia was that, again, this is the largest trial that we have, invasive versus conservative therapy. Overall, whether you use an initial invasive therapy compared with a median of 3.5 years, whether you looked at primary endpoints, at secondary endpoints. I will say, however, and again, this is very unlikely due to chance that this is a real finding. However, this patient underwent a two-vessel angioplasty, which I suspect a lot of my colleagues in the United States would have done. So the question is, how long should he be prescribed dual antiplatelet therapy in the setting of stable ischemic heart disease? So again, raise your hand if you have an answer here. 1 month, 3 months, 6 months, 1 year, or greater than 1 year? And so the answer is it could be any of these, depending on a lot of your understanding of this person's risk and what type of stent he had, or whether he had a bleeding profile or whatever. This is sort of the conundrum that we have related to dual antiplatelet therapy. So again, we had dual update in 2016. That recommendation said after patients with a drug-eluting stent, a PDY2 inhibitor therapy should be given with aspirin for at least 6 months. That's our standard answer. However, in some patients without a bleeding complication who may have significant risks related to ischemic disease, you could do it longer. In patients who have a high risk of bleeding, you can discontinue the PDY12 inhibitor after 3 months being a reasonable therapy. So what about this issue about prolonged DAPT, or dual antiplatelet therapy? It's interesting to talk about this because a lot of the recent trials have been talking about shortening the time. But if you look at a couple key trials, Charisma or the DAPT trial or Pegasus, there is some benefit in terms of prolonged DAPT therapy in some patients, particularly those with prior myocardial infarction, which you may actually decrease ischemic events over 1 to 3%, but at a cost, of course, of increased bleeding. And that actually has a 2B indication from the DAPT trial, DAPT update. What about the issue of aspirin? Again, the important point here is that the dose of aspirin, which is very important in terms of the risk of bleeding, particularly in the setting of DAPT. And we have learned that the sweet spot here is using aspirin between 75 and 150 milligrams. I'm guessing here it's 100 milligram is your pill that you use, or do you use 81? 75? And that's the recommendation, of course. In the United States, typically 81 milligrams in terms of minimizing the risk of bleeding, but obtaining the benefit related to aspirin. In terms of the dual antiplatelet therapy, it's again weighing the ischemic risk with the bleeding risk. In the United States, we have 3 antiplatelet PDY12 inhibitors. I will guess, correct me if I'm wrong, that prasugrel is not a player here. You have all 3? All 3. And, but you can see we have the irreversible aspects of prasugrel and clopidogrel, again with the prodrugs of those, and ticagrelor, which is a reversible active drug. Ticagrelor is kind of particularly interesting in the present environment because not only has it been shown beneficial over clopidogrel, and particularly related to the Plato trial in terms of adverse cardiovascular events, with a pretty good bleeding and safety profile, although increased bleeding with non-cabbage bleeding, both major and TIMI major, and with mild other safe effects. But the particular excitement that we have with ticagrelor is right now we have developed a antidote that works immediately. And although we know it's safe, we're still now looking to see whether it's safe and effective. And so that may give ticagrelor an advantage over time because, needless to say, bleeding on a DAPT therapy is a nightmare for all involved. When we look at the NSTEMI guidelines with ACS, clopidogrel or ticagrelor up to 12 months with using a load and maintenance without contraindications is a 1B. If you try to choose between the 2 inhibitors, it is reasonable, a 2A indication, to choose ticagrelor over clopidogrel and prasugrel over clopidogrel after coronary stent implantation if the patient has no history of stroke and TIA. Again, looking at our update, our focus update, I put new in quotes because this is the algorithm that was created in 2016. The point being that the new algorithm was if you had a high bleeding risk with ACS, a drug-eluting stent, reasonable to stop after 6 months versus the 1-year recommendation in general with ACS. and again, a 2B indication for long-term utilization after that on high-risk patient, ischemic risk patients. In stable angina, again, 6-month recommendation, but 3 months in patients with high bleeding risk. A patient population particularly under treated, in my mind, is patients after coronary artery bypass surgery, where recommendations from our guidelines still say that we should utilize dual antiplatelet therapy if the patient had an ACS up to 12 months. A topic that I'm going to spend more time on tomorrow is the nasty issue of triple therapy, patients who require oral anticoagulants, typically for atrial fibrillation, and how we manage these patients. We need to assess their ischemic and bleeding risk. We need to keep the triple therapy as short as possible. In general, we try to choose clopidogrel as the inhibitor of choice because it's a little less potent than some prasugrel and ticagrelor. Obviously, we use the low dose of aspirin. If we're using warfarin, a vitamin K antagonist, we shoot for an INR a little lower. And PPI, certainly in a patient with a history of GI bleeding, are reasonable, or even in patients that are at higher risk. One of the challenges we have in trying to figure out length of dual antiplatelet therapy is we look on the left in the terms of increased ischemic risk in patients with stent thrombosis that actually favors longer duration of dual antiplatelet therapy. You can see them right there. You can scan them yourself, versus the patients on the right who have an increased bleeding risk, which favors a shorter duration of dual antiplatelet therapy. And quickly you would realize that there are a lot of common risk factors for both bleeding and for ischemia that we have to wrestle with in making these decisions. People look at risk scores to try to help in terms of making these decisions. The DAPT score was based on the DAPT trial. Notice in particular, when one does this, that the patients particularly that have less benefit for longer duration of antiplatelet therapy are the elderly or patients over 65, which certainly are a huge proportion of the patients that we actually treat. Underappreciated and not dealt with in a lot of these DAPT scores and so forth, but what concerns the interventional cardiologist is actually the complexity of the coronary artery disease itself. So if you have a patient who's had triple vessel disease, multiple stents, bifurcation with 2 stents, long stent lengths, we know that those patients with complex PCI have a much higher ischemic risk than those patients with non-complex PCI, as shown by this trial. And there's recommendations, therefore, are favoring these complex PCIs with longer dual antiplatelet therapy versus shorter in less complex PCI. Again, something to be making in your decision process. So overall, what is my patient's risk of ischemia? That's one of the things we think about. What are my patient's risks of bleeding? What extent will this influence my decision for dual antiplatelet duration? How do I weigh the relative impact of bleeding in ischemic events? In general, I would consider longer DAPT in patients with an ACS, renal failure, poor ejection fraction, if the lesions are thrombotic or complex, if in your technique you're not using non-compliant balloons or imaging and afterwards to assure good coverage, or if you're using smaller overlapping stents. We should consider short DAPT if patients are stable angina, simple lesions, IVUS confirmation, and so forth. And as mentioned, not only is 6 months recommended, but new studies have been showing safety and efficacy with 1 to 3 month duration, particularly in stable ischemic heart disease. Take-home messages: patients' risk for stent thrombosis versus increased bleeding, and the duration of that will vary with the patient characteristics. Ongoing data for shorter duration of DAPT and a switch to monotherapy at 3 months or even maybe 1 month with newer generations, I think is the way of the future based on trials such as Seniors, DAPT, Smart Choice, and Twilight, where strategies of using maybe DAPT for a month or 3 months, followed by monotherapy with a PDY12 inhibitor, have been shown to be non-inferior or maybe even superior, but we don't have enough data yet to fully incorporate them in our guidelines, and we have no head-to-head trials in many respects. They're not well studied between the three drugs using these shorter duration therapies. So I have to say, at this time in the United States, we still need to follow our 2016 guidelines. It is no doubt in my mind that the next focused update of duration of DAPT will give a more succinct guideline to safe and effective strategy based on a lot of these recent trials and some that are ongoing. And certainly in select risk-benefit cases, it may be further appropriate to shorten DAPT. And again, thank you for having me in your great city. This is some pictures that we had in touring just 2 days ago. Thank you very much.
Yeah, so there was excellent session by Dr. Brindis. And guys, if you have any questions, you can put the questions on the comment box, on the chat box. So let's start with the questions. I think we have a couple of questions right now. So which clinical characteristics benefit from extended duration of DAPT in SCS patients? So SCS patients, I would say, I think it was one of the excellent slide what Dr. Brindis has shown to us. The patient who have recurrent ACS events, like recurrent history of the myocardial infarction in the past, the patients who have ACS with the diabetes, the patients who have ACS with the CKD, even CKD is again a risk factor for the bleeding as well. But yes, it is a high risk patients, and those patients we need to consider DAPT, prolonged DAPT beyond the 12 months. ACS patients with the, I would say, high risk coronary features, like in the angiography, you can see the diffuse disease, diffuse triple vessel disease, or left main disease. I would say stent restenosis kind of thing, or stent thrombosis kind of thing. These kind of patients require prolonged DAPT beyond the recommended duration. The next question is, what factors should we keep in mind while discussing the optimal duration of the DAPT? So the same thing what we discussed right now. Basically, for the DAPT, you need to balance between the bleeding risk as well as the ischemia risk. And we have various scoring system as well. But in general, when the bleeding risk is high, you can consider to give the DAPT for the shorter duration and convert them to the single antiplatelet after a certain period of the time, especially after the 6 months of the time. So at least 6 months, all of the patients should be given the DAPT. But if the ischemia risk is high, the patient who are at more risk for the future events, those patients we should or we must prolong the DAPT up to the 12 months or even beyond that. But the bleeding risk is high, then we should stop the DAPT and convert the patients on the single antiplatelet, preferably ecosprin or the clopidogrel, after 6 months of the time. Okay, so the next question is, how can doctors modify the therapy for patients with the ACS? Okay, I think it is, we don't need to modify any therapy for the ACS. There are always set protocols and the set guidelines which we need to follow in all patients of the ACS. Basically, I'll just briefly tell you, ACS we can divide into three categories. Number one is unstable angina. Number two is non-ST elevation MI, and number three is ST elevation MI. So in how to differentiate between these three is that unstable angina, troponin will be normal or negative, while in case of NSTEMI and the STEMI, it will be positive. And how to differentiate NSTEMI and STEMI? You can see the ECG. If the ECG is showing clear-cut ST elevation, that will be the ST elevation myocardial infarction. If there is a no ST elevation but troponin is positive, then it will be a NSTEMI. The unstable angina diagnosis is more sort of based on the clinical presentation, plus or minus ECG changes. So there are set protocols for all these three acute coronary syndrome situation and how to treat all of them. So we may have a webinar on the management of the ACS in the future, but it will be beyond the scope of this discussion right now. Okay, so what are the main advantages and the disadvantages of newer generation stents? I would say disadvantages are very, very low, or I think there is no disadvantage in comparison to the previous generation stent. But yes, advantages are there. Number one is less risk of restenosis. What was happening in the previous generation of the stents, the restenosis rate has come down. And number two, the more important thing is the stent thrombosis. And duration of the DAPT, we can reduce the duration with the newer generation, few of the newer generation stents in comparison to the older generation stent. You might have heard about the Cypher stent. That was, I think it was the first generation stent. Years ago, it was, I think, almost 10 years ago, it was like the only stent available. And the majority of the cardiologists were putting the Cypher stent. Uh, the bad thing about the stent is that we need to give the DAPT for almost lifelong, because the stent is creating so much problem. The thickness of the stent strut and the generation of it was the older generation. The risk of stent thrombosis is very high with that, which is not there with the newer generation stents. And luckily, we can stop the DAPT even after 3 months in some patients with the newer generation stents. So that is the main advantage of the newer generation stents over the older generation stents. Okay, the next question is, which antiplatelet in alcoholic cirrhosis? Okay, so I would say in alcoholic cirrhosis it is very difficult to manage with the antiplatelet. Uh, Ideally, we can give clopidogrel, which is more gastric favoring, like I would say less gastritic or other GI bleeding effect with the clopidogrel. But more important thing is in the cirrhosis patient, uh, esophageal varices and the platelet count. These two things we need to always consider, because whenever there is a bleeding from the esophageal varices, it can be massive sometimes, and if the patient is on antiplatelet, that will be very difficult to manage. But yes, for the cardiac indication, we can safely give ecosprin or the clopidogrel. Preferably, I would like to give clopidogrel in those patients. Okay, so next question. Okay, so what is safe antiplatelet in case of recurrent GI bleeding in patients undergone PTCA with stenting, and how long? So just now we discussed about that clopidogrel will be better with the slightly better GI beneficial effect. And for the stenting, after stenting, at least 3 months of the DAPT is required. If there is a massive bleeding, we have to stop in between. But yes, if there is a high risk for the bleeding, we can stop the DAPT after the 3 months. Okay, dual antithrombotic drugs therapy is an accepted standard in AF patients undergoing PCI. If aspirin is contraindicated, which two drugs you recommend? Okay, regarding the atrial fibrillation, we need to give the oral anticoagulation, and that is one of the warfarin or acetron, that oral anticoagulant we need to add along with the aspirin and the clopidogrel. But if the aspirin is contraindicated, or even in the atrial fibrillation patient, we don't give aspirin after a certain period of the time, let's say after 6 weeks. So we can put those patients on the clopidogrel and the oral anticoagulant, either warfarin or acetron, or even nowadays they can recommend, and they are off-label indication of the newer anticoagulant drugs like rivaroxaban and apixaban kind of thing, so that we can combine with the clopidogrel. When we can't give the aspirin, we should not give it triple therapy beyond certain period of the time. Okay, so the next question is, sometimes we come across no reflow syndrome after PCI. 2B3 antagonist given IV is said to be helpful. What is your experience? Yes, excellent question. And actually, it is really helpful. Like in nowadays, it is like on table we need to decide to give the GP2B3 inhibitors. Specifically, what I recommend or what we usually follow is that to give those patients with the severe slow flow or no flow because of the high thrombotic burden in SCS patient, in SCS situation. Second important indication is to give it a stent thrombosis when the thrombus burden is very high. But yes, it is really helpful along with the DAPT in no reflow syndrome after PCI when there is a high thrombus burden. And we give it routinely for 24 to 48 hours, or even sometimes intracoronary after the PCI when there is a no reflow. Okay, next question is, have you ever experienced aspirin resistance? How clinically anyone suspect aspirin resistance? Yeah, it's again a good question. Aspirin resistance as well as the clopidogrel resistance is very common. I would say they say up to 30% of the population, in Asian population, this kind of scenario can present. So as an interventional cardiologist, nowadays we don't recommend or we don't give it clopidogrel in the post PCI patients. Usually we give the ticagrelor and the prasugrel because we don't want this kind of resistance in our practice. The good thing clinically how to find that thing is that we can see the patient on already on the aspirin and having recurrent ischemia, let's say recurrent MI or recurrent unstable angina. That means those kind of patients might have aspirin resistance, and we can switch over the patient from aspirin to some other antiplatelet agent, or preferably the newer antiplatelet agent. Okay, so the next question is how often clopidogrel resistance? Again, the same thing. Genetic study should be done. Okay, yeah, it's a very good question. There are few genetic studies available, but it is really costly in the clinical scenario. We usually, as I mentioned you before, that we don't usually do the genetic study to look for the clopidogrel resistance because we have the newer antiplatelets agents available like prasugrel and the ticagrelor, which are excellent and which usually overcomes the drawback of the clopidogrel resistance. Okay, so is there any role of reducing dose of ticagrelor to half the dose after 6 months in a case of elective non-emergent PCI with favorable coronary anatomy? Guys, I recommend, I would tell you that there is nothing like reducing dose to half to the ticagrelor prior to the surgery or even the routine dose. It has to be stopped 3 to 5 days, preferably 5 days prior to the surgery when it is a high risk surgery, high bleeding risk for the surgery. And after 6 months, not like that, but after 1 year, we can reduce to 60 milligram twice daily based on certain clinical evidence in the patient with the high risk of the ischemia in the future. So reducing half dose of the ticagrelor after 6 months is not at all indicated, and it is not generally recommended in any of the guidelines. Okay, I think this will be the last question. Are there any indication for the BM stent, bare metal stents? Okay, very good. So, with the clinical latest development in the stent technology, I think there is very few indications for the bare metal stents. I would say specifically, we use it very rarely, first of all, but we use it when there is a high risk for the bleeding, and we don't, and the patient cannot tolerate the DAPT for the longer duration. So in this situation, we can use a bare metal stent. Otherwise, in routine clinical scenario, it will be, I would say, less than 1% or less than 2%. All over the PCI happened all over the world. Bare metal stents are used. Okay, and then one more question. Okay, let's go with that. Is there any subset of the patient who are at high risk of bleeding with ticagrelor, like those with body weight less than 60? Oh, good question. So I think you have asked this question in perspective of the prasugrel. We can't give the prasugrel when, or it's a contraindication, or the bleeding risk is high when prasugrel is given to the patient with the weight less than 60 or the prior history of the TIA or stroke. It is not the same thing with the ticagrelor. You can safely give those patients ticagrelor because there is no such contraindication with the ticagrelor. It is very safe and no bleeding, extra bleeding risk with the ticagrelor in this situation. Okay, so I think we have done all the questions. So I hope you all have enjoyed the this academic fiesta and the webinar, and we will come up with the more webinar with the Docplexus in the future. Thank you for joining with